Hello everyone and welcome. I'm glad you're here today. We're about to start a presentation on human immunodeficiency virus, or HIV. This is the first slide, which serves as our cover. Over the next few minutes, we'll explore what HIV is, how it affects the body, and what steps can be taken to prevent and manage it. But for now, let's get started, and I look forward to sharing this important information with you. HIV belongs to the lentivirus subgroup of the family Retroviridae. This means it's part of a larger group of viruses known for their ability to integrate into the host's genome and cause persistent infections. The lentiviruses are particularly interesting because many of them cause immunodeficiency in primates, including humans. Within this group, we have the human immunodeficiency viruses, or HIV, which are classified as types 1 and 2. These are the main culprits behind AIDS in humans. There are also simian immunodeficiency viruses, or SIV, which infect primates like monkeys and apes. Interestingly, studying SIV has helped us understand how HIV evolved and how it affects the immune system. So, in essence, the key point here is that HIV is part of this larger family of lentiviruses, many of which can cause serious immune problems in primates, including us. This connection is crucial as we explore how these viruses operate and how they impact health globally. Let's take a closer look at the structure of HIV, as shown in this diagram. HIV is a spherical enveloped virus, which means it has a round shape and is surrounded by a lipid membrane. Its size ranges from about 90 to 120 nanometers, making it quite small but still complex in structure. Inside, it contains two identical single-stranded RNA copies, and these are positive sense RNA, meaning they can be directly used for protein synthesis. These RNA strands also carry the enzyme reverse transcriptase, which is crucial for the virus's replication process. On the surface of the virus, you'll notice knob-like glycoprotein spikes. These are essential for the virus to attach to and enter host cells. Additionally, there are transmembrane pedicles, which span the viral envelope and play a role in the virus's interaction with host cell membranes. Once inside the host cell, the viral RNA is reverse transcribed into double-stranded DNA, a process that transforms the virus into a provirus. This provirus then integrates into the host's genome, allowing the virus to hijack the cell's machinery for its replication. Understanding the morphology of HIV helps us grasp how it infects and persists within host cells, which is fundamental as we explore strategies for intervention and treatment. Let's take a closer look at the structural gene, specifically the GAG gene. This gene plays a crucial role because it determines the core and shell of the virus, including a protein called P24. Now, P24 is particularly important because it can be detected in the serum during the early stages of HIV infection, even before the body starts producing detectable antibodies. This makes P24 a useful marker for early diagnosis. Additionally, monitoring the levels of P24 and anti-P24 antibodies gives us insight into the progression of the disease. When the infection worsens, there's often a decline in free anti-P24 antibodies, and at the same time, P24 antigen reappears in circulation. This fluctuation indicates an exacerbation of the illness, helping us understand how the virus is evolving within the host. Overall, understanding these viral genes and antigens is key to grasping how HIV behaves and how we can detect and monitor the infection effectively. All right, let's delve into the ENV gene first. This gene is crucial because it determines the synthesis of the envelope glycoprotein, specifically GP160. Now, GP160 is initially produced as a single precursor protein, but it doesn't stay that way. It's cleaved into two important components, GP120 and GP41. These two play vital roles in the virus's ability to infect host cells. Moving on to the Pol gene, this one codes for the polymerase reverse transcriptase, which is essential for converting the viral RNA into DNA inside the host cell. It also encodes other viral enzymes that support the replication process. What's particularly interesting is that besides these structural genes, there are also non-structural and regulatory genes that are specific to the virus. The products of these genes, whether structural or non-structural, act as antigens. That means they are recognized by our immune system and are very useful for diagnostic purposes, helping us detect and understand the progression of HIV infection. So, in summary, these viral genes and their antigens are not just about the virus's structure and replication. They're also key targets for our diagnostic tools, which is a critical part of managing HIV. This slide doesn't contain enough information. That's why we're moving to the next slide. Now, let's take a closer look at the major antigens of HIV, starting with the envelope antigens. The principal envelope antigen is GP120, which is crucial because it plays a key role in the virus's ability to attach to and enter host cells. Along with GP120, there's also the transmembrane pedicle protein, GP41, which helps facilitate the fusion of the viral envelope with the host cell membrane. Moving on to the shell antigen, we have the nucleocapsid protein, P18, which forms the protective shell around the viral RNA. This shell is essential for protecting the genetic material as the virus travels and infects new cells. Next are the core antigens. The main one here is P24, which is often used as a marker in HIV testing because it appears early in infection. Besides P24, there are other core antigens like P15 and P55, which also contribute to the structure and function of the virus. Finally, we have the polymerase antigens, which include P31, P51, and P66. These are components of the viral reverse transcriptase enzyme, vital for the virus's replication process inside host cells. Understanding these antigens is fundamental because they are key targets for diagnostics, vaccines, and therapeutic interventions. Recognizing their roles helps us grasp how HIV interacts with the host and how we can develop strategies to combat it. Let's now look at antigenic variation, which is a key factor in HIV's ability to evade the immune system. This variation occurs primarily because of the error-prone nature of reverse transcription. Since reverse transcription is inherently prone to mistakes, it introduces mutations in the viral genome. These mutations lead to changes in the viral proteins that are recognized by our immune system, making it harder for the body to mount an effective response. This high mutation rate results in significant molecular and antigenic differences among HIV strains. As a result, we classify HIV into two main types, HIV-1 and HIV-2. These types differ not only genetically, but also in their geographic distribution and pathogenicity. The overall diversity and antigenic variation of HIV are crucial because they influence how the virus spreads, how it evades immune defenses, and how challenging it is to develop effective vaccines. This ongoing variation underscores the importance of continuous research and adaptable strategies in our fight against HIV. Today, I want to introduce you to the different subtypes of HIV-1. There are 10 subtypes, labeled from A to J, and all of these are part of what we call Group M, which stands for major because it's the most widespread group. Among these, subtype A is the most prevalent worldwide, meaning you'll find it in many different regions. However, the distribution varies depending on where you are. For example, in the Americas and Europe, subtype B is the most common. If we look at India, the subtype that dominates there is subtype C. Understanding these subtypes is important because they can influence how the virus spreads and responds to treatment. It also helps us grasp the global diversity of HIV and how it adapts to different populations. So, recognizing these patterns is a key part of our overall effort to control and eventually end the HIV epidemic. So, the first case of HIV-2 was isolated from West Africa back in 1986, which really marks a key point in understanding its origins. Unlike HIV-1, HIV-2 shares only about 40% of its genetic material with HIV-1, highlighting that they are quite different at a molecular level. Interestingly, HIV-2 is closely related to SIV, or simian immunodeficiency virus, which suggests it originally jumped from primates to humans. Another important aspect is that HIV-2 is much less virulent than HIV-1, meaning it generally causes less severe disease and progresses more slowly. This partly explains why HIV-2 has remained largely confined to West Africa, unlike HIV-1, which spread globally. When we look at the subtypes of HIV-2, we see a variety, which reflects its genetic diversity within the region. Understanding these subtypes is crucial for developing targeted treatments and prevention strategies. Overall, these points help us piece together the complex history and behavior of HIV-2, especially in the context of the global HIV/AIDS epidemic. Universities Press PVT Limited. Today, I want to talk about the transmissibility of different HIV subtypes and how they vary depending on geographic regions and modes of transmission. In Asia and Africa, the subtypes called C and E are quite common. These subtypes are more easily transmitted through heterosexual contact, which reflects the predominant modes of transmission in those regions. On the other hand, in the United States, the predominant strain is subtype B. This strain tends to spread more through blood-to-blood contact, such as through injections or homosexual contact. Understanding these differences is crucial because it helps us tailor prevention strategies that are specific to the dominant subtypes and transmission routes in each region. Overall, recognizing how different HIV subtypes spread highlights the importance of targeted public health interventions, and it brings us a step closer to controlling the epidemic globally. Now let's talk about how we can inactivate the HIV virus. It turns out that HIV is quite sensitive to certain disinfectants and conditions. For example, it can be inactivated in just 10 minutes by treatment with 50% ethanol or 35% isopropanol. Additionally, solutions like 0.5% Lysol, 0.5% paraformaldehyde, 0.3% hydrogen peroxide, 1% nonidate P40, or even household bleach at 10% concentration are effective. It's also important to note that the virus can be inactivated at the extremes of pH, specifically at pH 1 and pH 13. This indicates that very acidic or very alkaline environments can neutralize the virus. When it comes to surface decontamination, especially with bleaching agents, household bleach or bleaching powder are commonly used. The standard recommendation is a hypochlorite solution with about 0.5% available chlorine, which is roughly 5 grams per liter or 5,000 parts per million. For contaminated medical instruments, a 2% solution of glutaraldehyde is typically used to ensure proper sterilization. Understanding these inactivation methods is crucial because they help us control and prevent the spread of HIV, especially in healthcare settings. It's all about applying the right disinfectants at the right concentrations and conditions to effectively neutralize the virus. Let's start by looking at the isolates from different carriers and patients. HIV isolates from asymptomatic carriers, those who don't show symptoms, tend to be strains that grow quite slowly. In contrast, isolates from AIDS patients are usually strains that grow faster. This difference in growth rate can tell us a lot about the progression of the infection and how the virus behaves in the body. Moving on to susceptibility, it's important to note that HIV is thermolabile. That means it's sensitive to heat. For example, it gets inactivated in just 10 minutes at 60 degrees Celsius and even faster, within seconds, at 100 degrees Celsius. So, heat is a very effective way to kill the virus. At room temperature, which is around 20 to 25 degrees Celsius, and even in dried blood, HIV can survive for up to 7 days. That's a significant period, especially considering how easily it can be transmitted if proper precautions aren't taken. Additionally, HIV has been isolated from various tissues during autopsy, up to 16 days after death. This highlights how resilient the virus can be in different environments post-mortem. Another point to remember is that HIV can withstand lyophilization, or freeze-drying, which is a process used to preserve biological samples. This resilience to different preservation methods further emphasizes its stability under certain conditions. Now, regarding growth characteristics, understanding these differences is crucial for diagnostic and research purposes. The variation in growth rates and stability helps us comprehend how the virus persists and spreads, reinforcing the importance of effective handling and inactivation methods in our overall efforts to control HIV. Let's talk about the epidemiology of HIV today. The main types of HIV-1, which are M, O, and N, each have their own unique origins. These types resulted from independent transmissions from chimpanzees to humans, which is quite fascinating because it shows multiple cross-species transmission events. The most common and widespread of these is HIV-1 group M, which is responsible for the global pandemic. Now, moving on to HIV-2, which is less common but still significant. Its source is traced back to a different primate, the sooty mangabey monkey, known scientifically as Cercospis aedes. This indicates that HIV-2 originated from SIV, the simian immunodeficiency virus, that was transmitted from these monkeys to humans. Understanding these origins helps us grasp how zoonotic transmissions have played a crucial role in the emergence of HIV. It connects to the broader theme of how viruses can jump species barriers and lead to widespread epidemics. Recognizing these zoonotic pathways is essential in our efforts to prevent future outbreaks. Once the virus enters the bloodstream or tissues of a person, it encounters a suitable host cell, most commonly the CD4 lymphocyte. This is a crucial step because these cells are the primary targets for the virus, and their destruction leads to the immune system weakening over time. When we talk about transmission, the main route is through sexual contact, whether heterosexual or homosexual. This highlights how important safe sex practices are in preventing the spread. The virus can also be transmitted through blood and blood products, such as during transfusions or through organ transplantation. That's why screening blood donors, including testing for the P24 antigen, is so vital to prevent new infections. Needle sharing among drug addicts is another significant route, emphasizing the importance of harm reduction strategies. Healthcare workers are at risk too. Needle stick injuries can cause iatrogenic infections, which reminds us of the importance of proper safety protocols. Lastly, mother-to-child transmission can occur at various stages, before birth, during delivery, or through breastfeeding. Understanding these pathways is essential for developing interventions to protect both mother and child. All these routes underscore how the virus exploits multiple opportunities to infect new hosts, which is why comprehensive prevention strategies are so critical in controlling its spread. Let's take a closer look at the initial steps in the pathogenesis of HIV infection. The first key point is about cell receptors for virus attachment. HIV specifically targets cells that have the CD4 antigen on their surface, primarily CD4 plus T lymphocytes, which are crucial players in our immune response. The virus attaches to these cells through the envelope protein GP120, which binds directly to the CD4 receptor. This interaction is essential because it allows the virus to latch onto the host cell and begin the process of infection. Once the virus binds, the next step involves cell fusion, which is facilitated by another viral protein called GP41. This protein helps the viral envelope fuse with the cell membrane, allowing the viral core to enter the host cell. Now, for the virus to effectively infect different cell types, it also relies on coreceptor molecules. There are two main coreceptors involved, CXCR4 and CCR5. CXCR4 is primarily used by T-cell-tropic HIV strains, which tend to infect T lymphocytes more efficiently. On the other hand, CCR5 is used by macrophage-tropic strains, which target macrophages. Understanding these interactions is fundamental because they highlight how HIV has evolved to exploit specific cell surface molecules to establish infection. This step in pathogenesis connects directly to how the virus spreads and persists within the host, ultimately impacting disease progression and potential treatment strategies. Now, let's take a closer look at Figure 21.3, which illustrates how HIV replicates in a susceptible cell. As you can see, this process involves the virus binding to specific receptors on the cell surface, namely CXCR4 and CCR5. These receptors act like entry points, allowing the virus to attach and fuse with the cell membrane. Once inside, HIV hijacks the cell's machinery to replicate itself, producing new viral particles. This image, sourced from the CDC's Public Health Image Library, really helps us visualize the microscopic steps involved in HIV infection. Understanding this mechanism is crucial, as it highlights why targeting these receptors can be an effective strategy in preventing or blocking infection. This process is central to our overall discussion of HIV's life cycle and how we can intervene to stop its progression. Let's talk about the process of HIV replication. First, the virus fuses with the host cell membrane, which essentially means it merges with the cell to gain entry. Once inside, the viral genome is uncoded and internalized into the cell, allowing it to access the cellular machinery. Next, the virus uses its reverse transcriptase enzyme to transcribe its RNA into double-stranded DNA. This step is crucial because it converts the viral genetic material into a form that can integrate into the host's genome. Then, the double-stranded viral DNA is integrated into the DNA of the infected cell, a process facilitated by another viral enzyme called integrase. This integration can lead to a latent infection, where the virus remains dormant within the cell, making it harder to detect and treat. Now, the primary pathogenic mechanism of HIV involves damaging the CD4 plus T lymphocytes, which are vital for our immune response. This damage gradually weakens the immune system, leading to increased vulnerability to other infections and illnesses. Connecting this to the overall theme, understanding this replication process highlights how HIV cleverly hijacks our cells to persist and cause ongoing immune damage, making treatment and prevention both challenging and essential. Now, let's look at what happens during replication in this context. T4 cells, which are a type of helper T cell, decrease in number. This reduction has a significant impact because it suppresses the cell-mediated immune response, making it harder for the body to fight off certain infections. But it's not just the cellular side that's affected. Humoral mechanisms are also impacted. What this means is that B lymphocytes, which produce antibodies, can become polyclonally activated. This leads to hypergammaglobulinemia, a condition characterized by elevated levels of immunoglobulins in the blood. Now, this might sound good at first, more antibodies, but it actually causes problems. The excess immune proteins can form immune complexes, which are responsible for allergic reactions and tissue damage. Additionally, monocyte and macrophage functions are also affected, impairing the body's ability to clear pathogens effectively. And it's important to note that the activity of natural killer cells and cytotoxic T lymphocytes, our immune system's frontline defenders, are also compromised. All of these changes together illustrate how the immune system becomes dysregulated during this phase, leading to increased susceptibility to infections and immune-related issues. This is a key part of understanding how immune suppression can develop and why managing these effects is so crucial. Let's take a closer look at some of the key immunological features that characterize AIDS. First, we see lymphopenia, which means a decreased number of lymphocytes in the blood. This is a hallmark of immune suppression. Next, there's a selective deficiency of T cells, particularly the T4 or CD4 cells. This reduction leads to an inversion of the T4 to T8 ratio, which is normally balanced. This shift is critical because CD4 cells play such a central role in coordinating immune responses. We also observe decreased delayed hypersensitivity on skin testing, indicating impaired cell-mediated immunity. This explains why individuals with AIDS are more vulnerable to certain infections. Another important point is hypergammaglobulinemia, mainly involving IgG and IgA antibodies. Despite the immune activation, this is somewhat paradoxical because it doesn't translate into effective protection. Instead, it reflects polyclonal activation of B cells, leading to increased spontaneous secretion of immunoglobulins. All of these abnormalities, decreased T cell counts, altered ratios, impaired hypersensitivity, and abnormal antibody levels, highlight how AIDS fundamentally disrupts both cellular and humoral immunity. Understanding these changes helps us grasp the profound immune deficiency that underpins the disease. On this slide, we're looking at some other features that are consistently observed in this condition. First, there's a decreased in vitro lymphocyte proliferative response to mitogens and antigens, which means that immune cells like lymphocytes don't grow or multiply as well when they're exposed to certain stimuli. This suggests a weakened immune activation. Next, we see a decreased cytotoxic response by T cells and natural killer, or NK cells. These cells are crucial for destroying infected or abnormal cells, so their reduced activity can compromise our body's ability to fight off infections or abnormal cell growth. We also observe a decreased antibody response to new antigens, which indicates that the immune system isn't responding as effectively when encountering unfamiliar threats. This can lead to increased susceptibility to infections. Additionally, there's altered monocyte and macrophage function. These cells play a key role in engulfing pathogens and coordinating immune responses, so changes here can impact overall immune regulation. Finally, we see elevated levels of immune complexes in the serum. These are clusters of antigens and antibodies that can deposit in tissues and cause inflammation or damage, which is often seen in autoimmune conditions. Putting this all together, these features highlight a pattern of immune dysregulation, reinforcing the overall theme of immune compromise or imbalance in the disease process we're discussing. Let's take a closer look at Table 21.1, which shows the classification system for HIV infections, as outlined by the Centers for Disease Control and Prevention in the USA. This table helps us understand how HIV progresses and how it affects the immune system. When the immune response begins to fail, the patient becomes more susceptible to opportunistic infections and certain malignancies. These are infections and cancers that typically wouldn't affect someone with a healthy immune system. This failure of immune response is a key clinical feature of HIV infection, especially as the disease advances. Recognizing these features is crucial for diagnosis and management. It also highlights the importance of monitoring immune function in patients with HIV to prevent or treat these complications early. So, in essence, as HIV progresses, the immune system becomes weaker, and patients become vulnerable to a range of health issues that can significantly impact their overall health and prognosis. Now, within about 3 to 6 weeks of infection, this is when the initial symptoms can appear. You might notice a low-grade fever, feeling generally unwell, some headaches, and swollen lymph nodes, which is known as lymphadenopathy. It's important to recognize that during this early phase, many people experience a spontaneous resolution of these symptoms within a few weeks. At this stage, we also have what's called seroconversion illness. This is when tests for HIV antibodies are usually still negative at the very start, but as the infection progresses, these tests turn positive. Interestingly, in many infected individuals, there may be no obvious clinical illness at all during this period. Then there's the acute retroviral syndrome, which some patients develop. These individuals might experience fever, fatigue, a rash, sore throat, or other symptoms. During this phase, we can sometimes detect HIV antigenemia, specifically the P24 antigen, which indicates the presence of the virus early on. All these points highlight how early HIV infection can present with a range of symptoms, or sometimes with none at all, making it a crucial period for diagnosis and intervention. Now, let's talk about the phase of symptomless infection, also known as clinical latency. During this stage, the virus is present in the body but isn't causing noticeable symptoms. This period can last for several years, often up to about a decade. Even though the person may feel fine, they are still positive for HIV antibodies, which means the immune system has recognized the virus. Importantly, during this time, the individual is still infectious, capable of transmitting the virus to others. Throughout this phase, the virus continues to multiply actively, although at a slower rate compared to earlier stages. This is why it's sometimes called the latent or asymptomatic infection. Understanding this stage is crucial because, even without symptoms, the infection persists and can progress if not managed properly. This group of individuals, often referred to as Group II, are in an asymptomatic or latent infection stage. They may feel healthy, but the virus is still present and capable of causing damage over time. Recognizing this helps us appreciate the importance of regular testing and early intervention to control the spread and impact of HIV. Let's take a closer look at the progression of HIV infection and its stages. Initially, we see CD4 lymphocytopenia, which means a decrease in CD4 T cells, a critical part of our immune system. During this phase, minor opportunistic infections may start to appear, signaling that the immune system is weakening. Persistent generalized lymphadenopathy, or PGL, is another early sign, where enlarged lymph nodes are spread throughout the body. Some individuals may experience what we call AIDS-related complex, or ARC, which includes symptoms like fever, weight loss, and fatigue, but not yet full-blown AIDS. As the disease advances, full-blown AIDS develops, characterized by severe immune deficiency. Interestingly, some people, about 5 to 10% of those infected, are long-term survivors or long-term non-progressors. These individuals manage to escape clinical AIDS for 15 years or more, thanks to various factors, including differences in immune response or viral load. Speaking of viral load, it's a key prognostic indicator. The amount of virus in the plasma helps us predict disease progression. As the CD4 plus T cell count drops below 200, the risk of developing clinical AIDS significantly increases, and the immune system becomes critically compromised. Overall, understanding these stages helps us grasp how HIV progresses and underscores the importance of early detection and management to improve patient outcomes. Let's take a closer look at enlarged lymph nodes in this context. When we see enlarged lymph nodes in 2 or more non-contiguous extrainguinal sites, that means they're not all in one area or closed together. It can be a sign of a more systemic process. If this enlargement persists for at least 3 months, and there's no current illness or medication that could explain it, that's a key point. It suggests a chronic condition rather than an acute or temporary issue. This situation is particularly important because it can potentially progress to AIDS-related complex, or ARC, or even to full-blown AIDS. So, persistent generalized lymphadenopathy, which we often abbreviate as PGL, is a significant indicator. It's a warning sign that warrants careful evaluation, especially in the context of HIV infection or other immune system issues. Overall, recognizing these patterns of lymph node enlargement helps us identify patients who might be progressing toward more advanced stages of immunodeficiency, and it underscores the importance of ongoing monitoring and early intervention. Let's take a closer look at some of the early signs that can indicate progression towards AIDS. Patients often present with symptoms like fatigue, unexplained fevers, and persistent diarrhea. These aren't just occasional issues, they tend to be ongoing and quite severe. Additionally, you might notice a significant weight loss, more than 10% of body weight, often described as diarrhea and dwindling. This combination of symptoms suggests the body is struggling to maintain its normal functions. As the disease advances, generalized lymphadenopathy, which is widespread swollen lymph nodes, and splenomegaly or an enlarged spleen become evident. These signs can develop quite rapidly, progressing to AIDS within just a few months if left untreated. This stage, known as Group IV, AIDS-related complex or ARC, is crucial because it marks a transition point where the immune system becomes significantly compromised. Recognizing these signs early can make a big difference in management and treatment strategies. Overall, understanding these early symptoms helps us identify when the infection is progressing and underscores the importance of timely intervention. Now, let's talk about what happens in the end stage of disease. At this point, there's an irreversible breakdown of the immune defense mechanisms. This means the body's ability to fight off infections and diseases is severely compromised. As a result, we see a progression of opportunistic infections and malignancies taking hold. These are infections and cancers that a healthy immune system would normally be able to control or eliminate. This stage is characteristic of acquired immunodeficiency syndrome, or AIDS. Essentially, AIDS represents the final, most severe phase of HIV infection, where the immune system is critically weakened, leading to serious health complications. Understanding this progression helps us appreciate the importance of early intervention and treatment to prevent reaching this critical stage. Let's take a closer look at Table 21.2, which highlights the major opportunistic infections and malignancies that are commonly associated with untreated AIDS patients. As we know, when the immune system becomes severely compromised due to the progression of HIV, the body loses its ability to fight off various infections and cancers. This table essentially underscores the types of infections and malignancies that tend to develop when HIV is left untreated, emphasizing the importance of early diagnosis and treatment. You'll notice that many of these opportunistic infections, such as pneumocystis jirovecii pneumonia, candidiasis, and cytomegalovirus, are much more likely to occur in individuals with advanced immune suppression. Similarly, certain malignancies like Kaposi's sarcoma and non-Hodgkin lymphoma are more prevalent in untreated AIDS patients, further illustrating how HIV can lead to a range of serious complications if not managed effectively. Understanding these associations helps us appreciate the critical need for timely intervention, not only to prevent these conditions, but also to improve overall patient outcomes. It reinforces the overarching theme that early ART initiation is key to preventing these severe opportunistic conditions and maintaining immune function. Let's take a closer look at Fig. 21.4, which shows pneumocystis jirovecii in lung tissue stained with methenamine silver stain. As you can see, this is a classic example of an opportunistic infection. Opportunistic infections are those that primarily affect individuals with weakened immune systems. In the respiratory system, the most significant pathogen we encounter is Mycobacterium tuberculosis. But we also see other infections like pneumonia caused by viruses such as CMV or fungal infections including pneumocystis jirovecii, cryptococcus, or histoplasma. These are particularly common in immunocompromised patients. Moving to the gastrointestinal system, opportunistic infections can manifest as oral and esophageal thrush, which is a form of candidiasis, or herpetic stomatitis and gingivitis. You might also see conditions like hairy leukoplakia and Kaposi's sarcoma, which are associated with immunodeficiency, especially in HIV/AIDS. Additionally, gastrointestinal infections can include parasites and bacteria such as Cryptosporidium, Salmonella, atypical mycobacteria, and Cystisospora. Viruses like CMV and adenoviruses are also common culprits. In more disseminated cases, we might see strongyloidiasis spreading throughout the body. And there's a particular condition called gay bowel syndrome, which refers to chronic colitis in male homosexuals, often linked to various infections or inflammatory processes. Understanding these opportunistic infections helps us grasp the broader impact of immune suppression on various organ systems and highlights the importance of immune health in preventing these complex infections. Let's take a closer look at some of the opportunistic infections that can affect the central nervous system in patients with AIDS. As you can see in Fig. 21.5, Part A shows oral candidiasis, which is a common fungal infection, and Part B illustrates Kaposi's sarcoma on the heels of an AIDS patient. These images help us understand the diverse manifestations of opportunistic infections. In the context of the central nervous system, several pathogens can pose serious threats. These include Toxoplasma gondii, which causes toxoplasmosis, and Cryptococcus neoformans, responsible for cryptococcosis. Other notable agents are cytomegalovirus, or CMV, herpes simplex virus, and papaviruses. We also see bacterial infections like mycobacteria, as well as fungi such as Cryptococcus and Candida. These infections often lead to neurological symptoms, and in many cases, they can result in dementia if left untreated. This highlights the importance of early detection and treatment of opportunistic infections to prevent severe neurological damage. So the key takeaway here is that in immunocompromised individuals, especially those with AIDS, the central nervous system is vulnerable to a wide range of opportunistic infections. Recognizing these infections and understanding their manifestations is crucial in managing and improving patient outcomes. Let's delve into some of the key opportunistic infections and conditions we see in immunocompromised patients. Starting with malignancies, we often encounter Kaposi's sarcoma, which is a cancer that appears as purple or brown patches or nodules on the skin, particularly in HIV patients. Hodgkin's lymphoma and other non-Hodgkin's lymphomas are also more common in these individuals, reflecting a compromised immune system's inability to suppress abnormal cell growth. Moving on to cutaneous diseases, there's a wide range to be aware of. Herpes lesions are common, causing painful blisters, while candidosis or yeast infections often affect mucous membranes and skin. Xeroderma or dry skin can become chronic and seborrheic dermatitis presents as flaky, greasy patches. Other skin issues include prurigo, which causes itchy nodules, folliculitis, or inflamed hair follicles, impetigo, a contagious bacterial skin infection, and molluscum contagiosum, which causes small, umbilicated bumps. In terms of ophthalmic diseases, we see CMV retinitis, a serious viral eye infection that can lead to blindness if untreated. Herpes simplex virus can cause keratitis or retinitis, and varicella zoster can also affect the eye, leading to serious complications. Now let's talk about wasting syndrome. This is characterized by more than 10% involuntary weight loss, often accompanied by fever, chronic diarrhea, and fatigue. It's a sign of advanced disease and indicates a significant decline in overall health. Finally, all these conditions are part of the broader category of opportunistic infections, which take advantage of weakened immune defenses. Recognizing these signs and understanding their interconnectedness helps us better manage and support our patients through these complex challenges. Children with pediatric AIDS tend to develop humoral immunodeficiency early on, which means their ability to produce antibodies is compromised quite early in the disease course. This often leads to noticeable signs like children failing to thrive, as their growth and development are affected. Chronic diarrhea is also much more common among children with HIV, reflecting their weakened immune response and susceptibility to gastrointestinal infections. Additionally, lymphadenopathy, or swollen lymph nodes, tends to be more pronounced in children, indicating ongoing immune activation and response to infections. When it comes to specific infections, tuberculosis and opportunistic bacterial infections are frequently seen in pediatric AIDS cases, highlighting the vulnerability of these children to illnesses that wouldn't typically cause such severe disease in healthy kids. We also observe lymphocytic interstitial pneumonia, a lung condition mostly seen in children with HIV, which can cause breathing difficulties and further complicate their health status. On the other hand, some conditions we associate with AIDS in adults, like Kaposi's sarcoma, toxoplasmosis, and cryptococcosis, are less common in children. Overall, these differences between adult and pediatric AIDS are important to understand because they influence how we approach diagnosis, treatment, and management in these young patients. Recognizing these early signs and typical patterns helps us intervene more effectively and improve their outcomes. Let's talk about laboratory confirmation of HIV and AIDS. When it comes to diagnosing these conditions, laboratory tests are essential because they provide concrete evidence of infection. The most common test is the HIV antibody test, which detects antibodies our body produces in response to the virus. Sometimes, it takes a few weeks after exposure for these antibodies to be detectable, so timing is important. Additionally, there are other tests like the viral load test, which measures the amount of HIV in the blood, and the CD4 count, which indicates how well the immune system is functioning. These tests don't just confirm the presence of HIV, they also help determine the stage of the infection and guide treatment decisions. It's important to emphasize that a laboratory diagnosis is the definitive way to confirm HIV infection or AIDS, especially since early symptoms can be vague or similar to other illnesses. Overall, these laboratory tools are critical in our efforts to diagnose, monitor, and manage HIV and AIDS effectively, keeping us aligned with the broader goal of controlling the epidemic. NACO recommends the use of ELISA kits that have a sensitivity of at least 99.5% and a specificity of at least 98%. Similarly, for rapid tests, the guidelines specify a sensitivity of at least 99.5% and a specificity of at least 98%. These high sensitivity and specificity levels are crucial because they ensure that the tests accurately identify those who are truly infected and minimize false results. In India, the National AIDS Control Organization, or NACO, has established clear guidelines and strategies for HIV testing to support effective diagnosis and management. The testing strategies incorporate different types of tests, including ELISA, rapid tests, and supplemental tests, which are used in various combinations across strategies I, and III. Supplemental tests come into play mainly when we encounter indeterminate or discordant results from the initial ELISA or rapid tests. These supplemental tests help confirm the diagnosis, especially in tricky cases where the primary tests don't provide a clear answer. Overall, these strategies and guidelines aim to ensure reliable, accurate testing, which is fundamental for controlling and preventing HIV transmission. They emphasize the importance of using tests with proven high sensitivity and specificity, and the strategic use of supplemental tests helps maintain diagnostic accuracy even in complex situations. Let's take a closer look at Figure 21.6, which interprets the results of strategy I tests. This particular strategy is primarily used to screen blood and blood products, as well as organs, tissues, and even sperm. The goal here is to ensure that these biological materials are safe for transfusion or transplantation. When we talk about strategy I, we're referring to a specific testing approach designed to identify potential infections or contamination in these materials before they are used. It's a crucial step in safeguarding recipients from transmitting infectious diseases. The interpretation of these tests helps us determine whether a sample is safe or if further testing is needed. Overall, strategy I plays a vital role in maintaining the safety and integrity of the materials used in medical procedures. Now let's take a closer look at Fig. 21.7, which illustrates strategy IIA. This strategy is specifically designed for surveillance purposes. When we talk about surveillance in this context, we're referring to monitoring situations where the data collected is anonymous and unlinked, meaning we don't have identifiable information tied to individual cases. Because of this setup, the strategy requires two tests to be conducted. The first test helps identify potential issues, and the second test confirms those findings, ensuring accuracy despite the lack of linkable data. This approach is particularly useful when privacy concerns prevent us from linking data, but we still need to keep an eye on the overall system health or detect anomalies. In essence, strategy IIA allows us to perform effective surveillance without compromising anonymity, but it does require a two-step testing process to ensure reliability. This ties into our broader theme of balancing privacy with effective monitoring, which is crucial in many real-world applications. Now let's take a closer look at Fig. 21.8, which illustrates strategy IIB, a specific approach used for diagnosing HIV in individuals who are either symptomatic or considered high risk. This strategy plays a crucial role in our overall efforts to identify and manage HIV cases effectively. The main goal here is to determine the HIV status of those suspected of having AIDS based on their clinical symptoms. When someone presents with signs that suggest AIDS, it's vital to confirm their HIV status quickly and accurately. Strategy IIB is designed for this purpose. It guides us on how to proceed with testing in these cases. This approach ensures that we don't miss opportunities to diagnose HIV early in symptomatic individuals, which is essential for timely treatment and preventing further transmission. So, in essence, this strategy helps us focus our testing efforts on those most likely to be HIV positive, especially when clinical signs point strongly to AIDS. It's a targeted, practical way to improve diagnosis rates among high-risk or symptomatic populations. By applying strategy IIB, we reinforce our overall goal of early detection and intervention, ultimately improving health outcomes and controlling the spread of HIV. Now, let's take a closer look at strategy III, which is specifically designed for detecting HIV infection in asymptomatic individuals. This approach is particularly relevant for those who come to integrated counseling and testing centers, or ICTCs, as well as prevention of parent-to-child transmission centers, or PPTCT centers. The key point here is that this strategy is used in people who don't yet show symptoms, so early detection is crucial. It involves a two-step testing process. The first test is the ELISA, which has the highest sensitivity. That means it's very good at picking up true positive cases and minimizing false negatives. If the first ELISA is positive, we then proceed with additional tests, the second and third ELISAs. These secondary tests are focused on having the highest specificity, which helps us ensure that the positive result is truly accurate, reducing the chances of false positives. So, in essence, this strategy combines a highly sensitive initial test to catch as many potential cases as possible, followed by highly specific confirmatory tests to verify those cases. This approach helps us efficiently identify HIV infections early, even in individuals who aren't showing symptoms, which is vital for timely intervention and preventing further transmission. Now, let's talk about early infant diagnosis, specifically for infants born to HIV-positive mothers. When we're testing infants under 21 months old, we use a method called DNA PCR, or DNA polymerase chain reaction. This test is crucial because it detects HIV-1 proviral DNA that's integrated into the infant's own genome. To perform this test, we typically collect either a small amount of whole blood or spots of blood dried on filter paper, which we call DBS, dried blood spots. The blood from the DBS is then eluted, or washed out, so we can extract the DNA. This DNA is what we use for the PCR test to determine if the virus is present. It's important to remember that for infants under 6 months, testing for HIV antibodies can be misleading. Because they still carry maternal antibodies from their mothers, the antibody tests might give false negative results. That's why DNA PCR is the preferred method in this age group. It's more accurate for early detection. Overall, early diagnosis is critical for timely treatment and better outcomes, especially in the context of mother-to-child transmission. Let's talk about viral isolation first. This method involves actually growing the virus in a laboratory setting, which can be quite definitive, but is often more complex and time-consuming. It helps us confirm the presence of the virus directly, but it's not always practical for routine diagnosis. Next, we have the detection of antibodies to various antigens of the virus. This is one of the most common approaches because it shows whether the immune system has responded to an infection. Detecting these antibodies can tell us if someone has been exposed to the virus, even if the virus itself isn't currently detectable. Moving on, we also look for viral DNA, RNA, or antigens. These detection methods are crucial because they can identify the virus directly, often earlier in the infection process. Techniques like PCR are able to detect even tiny amounts of viral genetic material, making them highly sensitive and valuable for early diagnosis. Overall, these methods, viral isolation, antibody detection, and direct viral detection, complement each other and form the backbone of HIV diagnosis. Each has its strengths, and together, they help us establish a clear picture of infection status. The P24 antigen is actually the earliest marker to appear in the blood when someone is infected with HIV. This makes it a really useful tool for early detection. The P24 capture assay is designed to detect this antigen directly. Now, it's important to note that the test is positive in about 30% of HIV-infected individuals. So, while it's a valuable marker, it doesn't catch every case on its own. It tends to be most useful during the recent infection phase, when the antigen is still present, or in the terminal phase of the disease, when viral levels are very high. Now, let's talk about seroconversion. This is a key concept. It's when IgM antibodies start to appear in the patient's serum after the initial period of P24 antigenemia and viremia. Essentially, it's the body's response kicking in after the virus is detectable through its antigens. Understanding these markers helps us piece together the timeline of infection and the immune response. Overall, antigen detection like P24 provides an important window for early diagnosis and monitoring, especially in the critical initial stages of infection. Let's take a closer look at Figure 21.1. On the left part, shows the sequence of appearance of the P24 antigen and antibodies following a massive HIV infection. Initially, right after infection, the P24 antigen becomes detectable, which indicates the presence of the virus itself. As the immune system responds, antibodies start to develop, eventually surpassing the levels of the antigen. This sequence is crucial because it helps us understand the timing of diagnostic markers during infection. Moving to Part B, we see an illustration of the typical course of immune response, viremia, and disease progression in untreated HIV-1 infection. Early on, there's a rapid increase in viral load, or viremia, which triggers the immune system to mount a response. Over time, you can see that the immune response initially controls the virus somewhat, but if untreated, the infection persists, leading to a decline in immune function and progression to AIDS. This figure really highlights the importance of early detection and understanding how the virus interacts with our immune system over time, which is key to developing effective treatment strategies. It ties into the broader theme of how HIV evades and eventually overwhelms the immune defenses if left untreated. Let's talk about some of the key methods we use for detecting viral nucleic acids. First, there's DNA PCR, which is a highly sensitive technique to amplify and detect specific DNA sequences from viruses. Then, we have RT-PCR, or reverse transcriptase PCR, which is essential for detecting RNA viruses by first converting their RNA into DNA before amplification. Another important method is the branched DNA, or bDNA assay, which is a different approach that amplifies signals rather than the target itself, making it useful for quantifying viral load. An interesting point to note is that dried blood spots on filter paper can be used as an alternative to plasma samples. This is particularly valuable in resource-limited settings because it's easier to collect, store, and transport dried blood spots without the need for cold chain logistics. In India, for example, dried blood spots are routinely used for early infant diagnosis, helping identify infections at a very young age when early intervention is crucial. Overall, these techniques are vital tools in our arsenal for detecting and monitoring viral infections, and understanding their applications helps us improve diagnosis, especially in challenging settings. It can take anywhere from 2 weeks to even up to several months for antibodies to actually show up after someone gets infected. During this time, the person is in what's called the window period, which is also known as the seronegative infective stage. Interestingly, during this window, infection can still be detected through a P24 antigen assay, which looks for a different marker of the virus. Now, as time progresses, IgM antibodies tend to disappear within about 8 to 10 weeks, but IgG antibodies stick around much longer, often throughout the person's lifetime. This is important because most antibody tests are designed to detect these IgG antibodies, which are the body's long-term response to the infection. Speaking of tests, anti-HIV antibody tests are used both for screening individuals and for confirming a diagnosis if there's suspicion of infection. So, understanding the timing of antibody appearance and the types of antibodies involved is crucial for accurate testing and diagnosis. This all ties back to the overall theme of how we detect and monitor HIV infection effectively. Let's take a closer look at Table 21.3, which outlines the serological markers detected during various phases of HIV infection. As the infection progresses, different antibodies and antigens appear and disappear, which helps us understand how the immune response evolves over time. In the initial acute phase, we typically see the presence of the P24 antigen, which is part of the virus itself. This marker appears early, often before symptoms develop, making it useful for early detection. As the infection moves into the chronic or latent phase, the body starts producing antibodies, specifically the HIV-specific IgM and later IgG antibodies. These antibodies are what most standard tests look for, and their appearance marks the transition to a more detectable immune response. Finally, during later stages, such as AIDS, the antibody levels might fluctuate or decline as the immune system becomes severely compromised. Understanding this timeline of serological markers is crucial for diagnosis and for identifying the stage of infection, which in turn influences treatment decisions. It also highlights the importance of timing when interpreting test results, especially in the context of recent exposure versus long-standing infection. This table really ties into the broader theme of how we detect and monitor HIV infection over time, helping us tailor our approaches to diagnosis and management accordingly. Let's talk about ELISA and rapid tests. These tests are known for their high sensitivity, which means they're very good at detecting those who actually have the condition. However, it's important to remember that they are not highly specific. This means they can sometimes give false positive results, indicating someone might have the condition when they actually don't. Because of this, any sera that test positive on a screening test must be confirmed with a more specific test before we declare the sample reactive. This step is crucial to ensure accuracy and avoid misdiagnosis. So, while these screening tests are powerful tools, they are just the first step in a reliable diagnostic process. Let's take a closer look at some of the key methods and reasons behind HIV screening. First, epidemiological surveillance through unlinked anonymous HIV testing allows us to monitor the spread of the virus in populations without identifying individuals. This helps us gather critical data to inform public health strategies. Next, ensuring transfusion and transplant safety is vital, as testing for HIV in blood and organ donors significantly reduces the risk of transmission through medical procedures. Accurate diagnosis of HIV infection is essential, whether the individual is showing symptoms or not, because early detection can lead to better management and treatment outcomes. Prevention of parent-to-child transmission is another crucial aspect, especially around pregnancy and childbirth, where interventions can drastically reduce the risk of the virus passing from mother to baby. For individuals exposed to potential HIV infection, post-exposure prophylaxis offers a window of opportunity to prevent the virus from establishing itself if taken promptly. Research continues to play a fundamental role in improving our understanding and approach to HIV, contributing to better testing, treatment, and prevention methods. The overall significance of HIV screening ties all these points together. It's not just about diagnosing individuals. It's about understanding the epidemic, protecting the safety of blood and organ supply, preventing new infections, and ultimately working toward controlling and eventually ending the spread of HIV. Let's talk about ELISA, or enzyme-linked immunosorbent assay, which is a fundamental technique in diagnostic testing. The most commonly used version of ELISA is the indirect ELISA. It's popular because it's relatively simple to perform and also cost-effective, making it accessible for many labs. Now, when we need more specificity, we often turn to competitive ELISA tests. These are designed to distinguish more precisely between similar molecules, which is especially useful in complex samples. Additionally, there's a specific type called capture ELISA, which is tailored for detecting IgM antibodies. This method is particularly useful when we want to identify early-stage infections, as IgM is often the first antibody produced in response to an infection. Overall, ELISA is a versatile tool, and choosing the right type depends on the specific requirements of the test, whether it's simplicity, cost, or specificity. Now, let's take a look at some of the various rapid tests available today. First up, we have the cassette ELISA, which is a simplified, quick version of the traditional ELISA test, providing faster results without sacrificing accuracy. Then, there are the immunochromatographic tests, or ICTs, which are commonly used because they are easy to perform and give rapid, visual results. Think of them as the little strips you might have seen in clinics. Next, we have coated particle agglutination tests. These work by using coated particles that clump together in the presence of a specific antigen or antibody, making it easier to detect infections quickly. Lastly, there are the immunoperoxidase or dipstick tests, which involve a small dipstick that reacts with the sample and produces a color change if the target analyte is present. All of these rapid tests are crucial tools in diagnostics because they enable quick decision-making, which is especially important in urgent or resource-limited settings. They complement our overall approach to disease detection and management, making testing more accessible and efficient. Now, let's discuss the process performed on serum samples that test reactive in screening tests. When we encounter discordant results, meaning two or more rapid or ELISA tests don't agree, we turn to confirmatory testing to clarify the diagnosis. The most commonly used confirmatory test is the Western blot. The key point here is that a positive reaction involving proteins from the three main genes, namely P24 from the GAG gene, which is the core protein, P31 from the Pol gene, which is reverse transcriptase, and GP41, GP120, or GP160 from the ENV gene, representing surface antigens, is considered conclusive. This means that if the Western blot shows reactivity with these specific proteins, we can confidently confirm the presence of infection. This step is crucial because it helps us differentiate true positives from false positives, ensuring accurate diagnosis and proper management. So, in summary, Western blot serves as a vital confirmatory or supplemental test, especially when initial screening results are uncertain. It provides a detailed protein profile that helps us make a definitive diagnosis. Now, let's take a closer look at the Western blot test for HIV antibodies, which is shown here in Figure 21.11. This test is a key confirmatory step after an initial positive HIV screening, helping us verify whether someone truly has HIV. The Western blot works by detecting specific HIV proteins, or antibodies, in the blood. Essentially, it separates the proteins and then uses a labeled antibody to identify if those HIV proteins are present. A positive result typically shows distinct bands at certain points, indicating the presence of antibodies against specific HIV proteins. This pattern helps confirm infection because false positives are less likely to produce this characteristic banding pattern. It's important to understand that the Western blot is a highly specific test, serving as a crucial part of the diagnostic process. It ties into our overall theme of understanding HIV testing strategies, distinguishing between initial screening and confirmatory tests to ensure accurate diagnosis. So, in essence, the Western blot provides us with a reliable way to confirm HIV infection when initial screening results are positive. Let's move on to slide 53, which focuses on serological tests. These tests are crucial because they help us detect the presence of antibodies in a person's blood. Essentially, they tell us if someone has been exposed to a particular pathogen, even if they aren't showing symptoms right now. One key point to remember is that serological tests are different from molecular tests, like PCR. While PCR detects the actual genetic material of the virus, serological tests look for the immune response, specifically antibodies. This makes them very useful for understanding past infections and immunity status. It's also important to note that these tests can help in epidemiological studies, giving us a clearer picture of how widespread an infection has been in a population. They can guide public health decisions, like vaccination strategies or lifting certain restrictions. However, we should keep in mind that antibody levels can vary over time, and not everyone develops detectable antibodies after infection. So, serological tests are just one piece of the puzzle. They complement other diagnostic methods to give us a comprehensive understanding of disease dynamics. In the context of our overall presentation, serological testing is a vital tool for tracking disease spread and assessing immunity, which ultimately informs our response strategies. Let's now turn our attention to the applications of serological tests. These tests are incredibly versatile and play a crucial role in various areas of medicine and public health. They are primarily used to detect the presence of antibodies in a patient's blood, which helps us understand whether someone has been exposed to a particular pathogen. This is especially useful in diagnosing infections where the pathogen itself might no longer be present or easy to detect. Serological tests are also vital for identifying immune responses, such as determining if someone has developed immunity after vaccination or natural infection. This information can guide vaccination strategies and public health policies. Additionally, they are used for epidemiological studies, helping us track disease prevalence and understand the spread within populations. And in some cases, serological testing can even assist in diagnosing autoimmune diseases, where the body produces antibodies against its own tissues. Overall, the applications of serological tests are broad and integral to disease diagnosis, monitoring immunity, and guiding health interventions. These tests are a cornerstone of modern diagnostic and epidemiological efforts, connecting directly to our overall goal of understanding and controlling infectious diseases. As we look at this slide, the key point is that virus titers closely parallel P24 titers, which helps us measure viral presence and activity. This process is done in containment laboratories, ensuring safety while handling infectious agents. To isolate HIV, the virus is obtained from peripheral lymphocytes through a method called co-cultivation. Essentially, we take the patient's lymphocytes and grow them together with uninfected, healthy lymphocytes. This is done in the presence of IL-2, which promotes lymphocyte growth and activation. This method allows us to effectively isolate the virus, providing crucial material for further analysis. Overall, this process is critical for understanding HIV's behavior and for developing diagnostic and therapeutic strategies. Let's discuss how to identify immunodeficiency in HIV infection. First, we look at the total leukocyte and lymphocyte counts. Often, you'll find leukopenia, which means the total white blood cell count is usually below 2,000 per cubic millimeter. This reduction indicates a weakened immune system. Next, T-cell subset assays are crucial. Specifically, the absolute CD4 plus T-cell count is typically less than 200 per cubic millimeter in these patients. Additionally, the T4 to T8 cell ratio, which usually balances around 1, is often reversed, showing a skewed immune profile. We also observe thrombocytopenia, meaning a low platelet count, which can contribute to increased bleeding risk. Serum immunoglobulin levels, particularly IgG and IgA, tend to be raised, reflecting immune system dysregulation. Diminished cell-mediated immunity, or CMI, is another key point. This can be assessed through skin tests, which often show a diminished or absent response, indicating compromised cellular immunity. Lymph node biopsies can reveal abnormalities as well, such as follicular destruction or other structural changes that support the diagnosis of immunodeficiency. Finally, there are nonspecific tests that help piece together this picture. Taken together, These findings form a comprehensive assessment of immunodeficiency in the context of HIV. Let's start by discussing the CD4 plus T cell count, which is a crucial marker in monitoring HIV infection. When the counts drop below 500, it generally indicates that the disease is progressing and the immune system is weakening. If the counts fall below 200, that signals a much higher risk of serious infections, meaning the immune system is severely compromised. Next, we have the viral load, which is essential to monitor throughout treatment. It measures the amount of HIV RNA in the blood and helps us understand how effectively the therapy is working. To do this, we use sensitive techniques like RT-PCR and bDNA assays, which provide accurate quantification of the virus. Finally, there are additional markers like beta-2-microglobulin and neopterin. These are helpful because they have predictive value regarding the progression of HIV infection. Elevated levels of these substances can indicate increased immune activation or disease progression, making them useful tools in comprehensive laboratory monitoring. Overall, combining these different markers gives us a clearer picture of how the infection is progressing and how well the treatment is controlling the virus. As we move on to this slide, it's important to understand that the loss of detectable anti-P24 antibody actually signals a significant change in the patient's condition. When these antibodies are no longer measurable, it often indicates that the immune system is weakening. This loss is also associated with HIV antigenemia, meaning that HIV antigens are now circulating freely in the bloodstream. Additionally, you see an increase in the virus titer, or the amount of virus present in the circulation. These combined factors, loss of antibodies, presence of antigens, and higher viral load, are all signs of clinical deterioration. They help us predict a worse prognosis in HIV infection, highlighting the importance of monitoring these markers closely throughout the course of the disease. Overall, this slide emphasizes how changes in immune markers and viral levels are crucial indicators of disease progression, guiding us in managing and anticipating the patient's clinical trajectory. Currently, there is no safe and effective vaccine against HIV infection. One of the biggest challenges in developing an HIV vaccine is the high mutation rate of the virus itself. This means the virus can change rapidly, making it difficult for our immune system or a vaccine to keep up and provide long-lasting protection. Another major obstacle is that HIV integrates its DNA directly into the host cell's genome. This integration allows the virus to hide within our cells, making it harder for vaccines to target and eliminate it effectively. Additionally, we still lack a complete understanding of how protective immunity against HIV works. Without knowing the precise immune responses needed to prevent infection, designing an effective vaccine becomes even more complex. So, when we talk about prophylaxis or preventive measures like vaccines, these challenges highlight why HIV remains such a tough target. Developing a vaccine requires overcoming these biological hurdles, which is why, to date, we haven't yet achieved a safe and effective solution. Let's take a closer look at Figure 21.12, which shows the guidelines of the National AIDS Control Organization, or NACO, regarding post-exposure prophylaxis, specifically focusing on the exposure code. When someone experiences a potential exposure to HIV, it's crucial to follow the appropriate steps based on the type of exposure they encountered. NACO's guidelines provide a clear framework to determine the correct course of action. The exposure code helps categorize the risk level, whether it's a high, moderate, or low-risk exposure. This classification guides us on whether to initiate post-exposure prophylaxis, or PEP, and the urgency with which it should be started. It's important to understand that timely intervention is key to reducing the chance of HIV transmission after exposure. By following these guidelines, healthcare providers can ensure that individuals receive the right treatment promptly, ultimately improving outcomes and preventing new infections. So, understanding and applying the exposure code correctly is a vital part of managing potential HIV exposure effectively. Let's take a closer look at Figure 21.13, which outlines recommendations for post-exposure prophylaxis, or PEP. This slide is important because it emphasizes the steps we should take immediately after potential exposure to prevent infection. First, it's crucial to assess the exposure risk carefully. Consider the type of contact, the infectious status of the source, and the nature of the exposure event. This helps determine whether PEP is necessary and what kind of intervention is appropriate. Next, if PEP is indicated, timing is everything. Starting prophylaxis as soon as possible, ideally within hours, maximizes effectiveness. Delaying treatment reduces the likelihood of preventing infection. The choice of prophylactic agents depends on the specific disease and the circumstances of exposure. Adherence to recommended drug regimens is vital to ensure maximum efficacy. Additionally, follow-up care is essential, monitoring for side effects, confirming the completion of the prophylaxis course, and conducting appropriate testing later to verify if infection was prevented. Overall, these recommendations highlight that prompt, appropriate action after exposure is key to controlling disease spread and protecting health. It's a critical part of our overall prevention strategy and ties into the broader theme of early intervention in infectious disease management. Highly active antiretroviral treatment, or HAART, remains the mainstay of HIV treatment. It's a powerful approach that works by targeting the virus at multiple points in its life cycle. One of the key benefits of HAART is that it leads to complete suppression of plasma viremia, meaning the amount of virus in the blood drops to undetectable levels. This not only helps protect the immune system, but also reduces the risk of transmission. Another important aspect is that by effectively controlling the virus, HAART decreases the rates of opportunistic infections. These infections are what often cause severe illness in people with HIV, so reducing their occurrence is a major step forward. Finally, I want to highlight the importance of adherence to treatment. Sticking closely to the prescribed regimen can delay the development of drug resistance. Resistance occurs when the virus mutates and no longer responds to the medication, making treatment more challenging. So, consistent adherence is crucial for the long-term success of therapy and maintaining the health of those living with HIV. Let's take a moment to look at Table 21.4, which covers antiretroviral drugs. These medications are crucial in managing HIV infection effectively. You'll notice that they are categorized into different classes based on how they work. For example, there are nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, and entry inhibitors. Each class targets a specific stage in the HIV life cycle, which is key to suppressing the virus. Understanding these categories helps us appreciate how combination therapy works. By using drugs from different classes, we can better prevent the virus from developing resistance. It's also important to recognize that the choice of drugs depends on various factors, including resistance patterns, side effects, and patient-specific considerations. Overall, this table underscores the complexity and the tailored approach needed in antiretroviral therapy, which is central to improving outcomes for individuals living with HIV. Let's take a closer look at Fig 21.14, which shows the site of action of antiretroviral drugs. As you can see, these drugs target different stages of the HIV life cycle, and understanding where they act helps us appreciate how they work together to suppress the virus. Some drugs inhibit the virus from entering the host cell, blocking the initial step of infection. Others interfere with reverse transcription, preventing the conversion of viral RNA into DNA. Then, we have drugs that inhibit integration, stopping the viral DNA from becoming part of the host genome. There are also agents that inhibit viral protease, which is crucial for producing mature, infectious viral particles. Recognizing these specific sites of action not only helps us understand the mechanism of each drug, but also underscores the importance of combination therapy in effectively managing HIV infection. This comprehensive approach targets the virus at multiple points, reducing the chance of resistance and improving patient outcomes. So, in the context of our overall discussion, understanding these mechanisms is key to appreciating how antiretroviral therapy has evolved to become more effective and tailored to combat HIV. Now, let's look at the treatment and prophylaxis of infections and tumors in managing AIDS. First, general management plays a crucial role, which includes not only medical treatment, but also rehabilitation and counseling. It's important to support both the patients and their families, helping them cope with the physical and emotional challenges they face. Next, we have immunorestorative measures. These involve providing protein-rich foods and nutritional supplements to help boost the immune system. Good nutrition is fundamental because it strengthens the body's natural defenses and improves overall health. Finally, specific anti-HIV agents are used to directly target the virus. These are essential components of managing AIDS, as they help suppress viral replication and delay disease progression. All of these strategies together form a comprehensive approach, addressing infections, tumors, and the broader health and psychological needs of the patient, highlighting the importance of a holistic management plan in HIV/AIDS care. For self-revision, I recommend pausing the video now and taking a moment to watch the attached content. This additional material will give you a clearer, more detailed understanding of what we've covered. Remember, revisiting these concepts helps reinforce your learning and ensures you're ready to apply them effectively. So, take that pause, watch the attachment carefully, and then continue with confidence.